I thank the ISA Thrissur branch for inviting me to deliver this talk. I also wish to thank Meera, who was one of my students from Kochi, for helping me procrastinate less. This is one of the first times I'm actually preparing a talk in advance. Otherwise, it's usually on the last day or the day of the talk. So because she insisted that it's recorded and sent well in advance, I've been forced to do this. I have no conflicts of interest. So today I'm going to talk to you mainly about encountering AF in the perioperative or more specifically in the intraoperative period, and try and outline some of the background rates, what you do, what AF actually can portend. So why do you need to know about AF? So AF is actually a common health problem. It's the most common sustained arrhythmia. It's as common as 1 to 2% of the population in the West has atrial fibrillation. Incidence in India is recorded to be much lower. However, with an overall aging world, incidence and prevalence of AF is bound to increase. Indian data actually suggests that although our burden of AF is lower, many of our patients are younger. They are often not systematically anticoagulated, and the death burden due to AS is much higher than the rest of the world. The other thing about AF is that, it asks us to look below the surface. As you will well know, in all exams, all anesthesia presentations, all anesthesia talks, there is overwhelming focus on coronary artery disease. But as this study from Alberta, a very large retrospective cohort will show, patients with heart disease who die or suffer major adverse cardiovascular events in the perioperative period don't often do it because of coronary artery disease. They maximally do it, they have heart failure. They actually also have a significant adverse event rate if they have atrial fibrillation. The other thing to point out is that AF is often associated or can be associated with heart failure. So AF and heart failure can together sink patients if they occur in concert. Remember this, and also AF makes the presentation of heart failure more acute and worse in patients who already have heart failure and then develop AF in the intraoperative period. That's the importance of knowing about AF. Small studies show that the risk from AF, new onset acute AF in the perioperative period, although rarely occurs intraoperatively, it most often occurs postoperatively, is not insubstantial. Patients with AF are 10 times as likely to die if they have new onset AF, and if they were compared to if they don't. The risks of acute AF are substantially higher than even those of chronic AF, about four times as high. This is a very famous epidemiologic cohort from Minnesota in the US, and they say the continued data that comes from that cohort shows that, the acute onset of AF after cardiac surgery increases your risks of getting a stroke tremendously, about 2.5 or 2.6 times. It also increases your risks of getting subsequent AF. So AF is a marker of getting AF again later in the well beyond the postoperative period, because besides substantially increasing your risks of stroke. There is some suggestion that also increases death, but the numerical risks are not as high. Data from the POISE trial showed that AF was associated with all-cause mortality, heart failure, myocardial infarction, because AF can be associated with an uncontrolled ventricular rate, shortens diastole, causes hemodynamic perturbation, and together they can precipitate coronary ischemia in the vulnerable patient. Of course, AF was also associated with a massively increased risk of stroke and a risk of significant bleeding. The maximal risks in patients with acute AF seem to be based on stroke. Most studies show a greatly enhanced risk of getting stroke. Although the studies about acute mortality are a bit equivocal, AF certainly, if you get AF in the perioperative period, it marks you at enhanced risk for all kinds of events in the medium term, well beyond the immediate post-op period. AF is dangerous because the patients who need atrial kick, those are the patients who have a high left ventricular end diastolic pressure. These are patients with either reduced ejection fraction or patients with diastolic heart failure. Both of these need the atrial kick to maintain cardiac output. So AF, when it removes the atrial kick, predisposes them to acute and severe hemodynamic instability. Of course, AF is associated with stroke, as we already harped on. The devil is in the details. This is how AF can precipitate coronary ischemia. I've already spoken about this. Stroke occurs because AF causes atrial dysfunction. Atrial contractile function deteriorates, particularly in the left atrial appendage. Because the contractile function deteriorates, you often have increased risk of vascular stasis, and that predisposes to thrombi, which then embolize. So who's at risk of AF? Why is it common enough to talk about during the perioperative? So AF shares lots of population risks in common with many other risks that you encounter in the patients that you do. These include heart failure, valve disease, coronary artery disease, and other risks such as renal failure, inflammation, COPD, obstructive sleep apnea is an important risk to consider because all of them are associated with the pan-inflammatory state that persists well before the perioperative period and then get exaggerated during this time. So that's why you have traditional risks, and then they meet these new risks brought on by perioperative stress, basically a pan-inflammatory stress state. There are other risks that can occur, such as, because of changes in volume status, or sometimes because of electrolyte abnormalities. So what exactly is AFS and arrhythmia? If, according to the guidelines, is defined, you need a 12-lead ECG or 30 seconds recording of a single lead to diagnose AF accurately. AF is characterized by absolutely no discernible P waves. You also see irregular PR intervals, RR intervals in the ECG. Now, the irregular RR intervals have an important caveat. Obviously, they assume that you have normal AV nodal functioning, no conduction abnormalities. Otherwise, your irregular RR interval could be due to these conduction abnormalities. We also talk of a variant, which is atrial flutter, and how it's differentiated from AF is like this. AF, fibrillatory waves, usually higher in frequency. They have lower amplitude. They're often variable in amplitude, whereas flutter has a sawtooth appearance, lower in frequency, and has relatively constitute amplitude and morphology. Sometimes you can't make out any atrial activity on the ECG, in which case, how do you detect AF? Basically by a varying RR interval. So if you have a varying RR interval in the absence of conduction abnormality, almost always it's due to atrial fibrillation. When you have very high heart rates, the RR interval may appear grossly normal and constant. However, you need to actually measure them, and when you document that there is variation, again, your diagnosis is most likely going to point towards AF. Finally, never ever forget that slow heart rates don't preclude AF. If you have a heart block, for example, you could have low ventricular rate, an escape rhythm basically, but in the background of AF. What should you do when you encounter it first? You ask these three questions. Is the patient hemodynamically stable? Is the ventricular rate controlled? Is this actually true new onset AF, or is it a paroxysm? Paroxysms are important because they usually die out within 24 hours, in which case patient needs to enter a paroxysmal AF pathway, and you don't need to do much about it as long as the patient's hemodynamically stable. Sometimes also you have permanent AF with intermittent periods of normalcy, and you need to ask, am I just seeing a new onset AF? Was the patient's basic background AF? I just encountered a brief period of normalcy, and then there's AF back again. All of these have great implications from the point of view of, can you cardiovert them? Because if you're looking at a background of permanent AF, cardioversion can't be immediately done unless you've done TE. So that's basically the idea behind asking all these three questions. If your patient's, however, hemodynamically unstable, that takes priority over everything else. You need to ask a small subsidiary question: is your heart rate above 110 or so? This is a rough guide, because if the rates are low, hemodynamic instability per se may not be because of AF, and you need to look at other factors. However, if your heart rate's is high and your patient's unstable, obviously you have to cardiovert them. Escalating energies are no longer recommended, so you use the highest energy on your DV for cardioversion. There are certain other situations in which you tend to tilt towards cardioversion. These are patients who have heart failure, who have valvular heart disease, critical coronary artery disease, previous venous thromboembolism with major stroke. You would tend to cardiovert them sooner or later, but under cover of anticoagulation or TE. So these are broadly the settings in which you would consider cardioversion for new onset AF. If your patient's stable, so this class 1 indication for cardioversion from the ESC guidelines suggests, of course, if you have acute or worsening hemodynamic instability. In those who fail to convert, you can give some consideration to starting amiodarone, because that's the only thing that you can do outside of cardioversion if you still want to give primacy to rhythm control over rate control. Why this great noise about cardioversion? The reason is that immediately after cardioversion, you get atrial stunning, and this causes poor left atrial function that aids thrombus formation. Stunning reverses quickly when your AF is of short duration, but can persist for weeks if AF has been long-standing. That's the importance of trying cardioversion only when your patients anticoagulate if you have doubts about how long AF has been around. And immediately after cardioversion, in most cases, you will have to give strong consideration to starting anticoagulation, which then is not easy to do in the intraoperative period, certainly, because you're undergoing surgery, and the immediate post-op period when surgical risks of bleeding preclude use of an anticoagulant. In some patients, you can seek an intermediate pathway, particularly when you think, oh, this patient really needs cardioversion, but you're not sure how anticoagulation will succeed. And that is, you can do TE, rule out clots in the left atrial or right atrial appendage, heparinize, and then do cardioversion, provided, of course, heparin is allowed. Okay, so a little bit about cardioversion. Electrical cardioversion succeeds more often than chemical cardioversion. However, when an antiarrhythmic drug is given, the chances of electrical cardioversion also increase. So versus when the patient's naive to an antiarrhythmic drug. Even if successful, cardioversion, if you succeed, you need to also address other background risks such as inotrope use, heightened sympathetic activity due to pain or hypothermia, and because these can all re-trigger AF. In select patients, you might not need anticoagulation, but these are patients who very rarely get AF. These are young patients who have no comorbidities. They have a CHA2DS2-VASc score, which is less than 1. That's taken to be the cutoff, and they may not need any anticoagulation if they have AF, which is typically less than 12 hours, but certainly also probably if AF is less than 24 hours. In most other patients, you'll have to start an anticoagulant. This is usually a direct-acting oral anticoagulant. In all AF, so this is basically some repetition of the previous slide. Most patients who have AF and cardioversion in the immediate perioperative period are anticoagulated, unless they have a very low CHA2DS2-VASc score. This anticoagulation is typically for a minimum of 4 weeks, so it can be longer if your CHA2DS2-VASc scores are higher. And non-oral, novel or direct-acting oral anticoagulants are what are typically used. This is an outline of that score. And this is another score, which is a Has-Bled score, which helps you decide whether anticoagulation can be continued longer when adjudged against a bleeding risk. If the patient is hemodynamically stable, rate control is the usual way to go. And this can be achieved with beta blockers or calcium channel blockers. There's some suggestion that beta blockers are more efficacious. In patients with grossly reduced heart function, ejection fraction, grossly reduced systolic function, may consider using digitalis, because that's probably the only remaining niche use for this drug. In all other patients, typically you would use a beta blocker. A little about chemical cardioversion via amiodarone. Remember, the risks of electrical cardioversion and chemical cardioversion are the same, so all the considerations for anticoagulation apply. Amiodarone is the most effective of these agents. It can be used in wide subsets of patients. Class 1 indication to use it in the setting of clinical cardioversion and heart failure. It's often not first line because of the significant extracardiac side effects of amiodarone, and it would be typically contraindicated to try amiodarone at all if you have some suggestion of clinical thyrotoxicosis. So these are two beautiful summary slides from a recent review in Anesthesia Analgesia, which says AF management is not about only the immediate intraoperative period, but a bit pre-op and a lot about it post-op as well, because you would need to take other clinical decisions such as anticoagulation, assess for heart failure. And these are all opportunities that are being used because of the patient coming for surgery or in the perioperative period. So you can be the referral physician actually, rather than the reverse, for documenting other risks and managing these risks well beyond the perioperative period. Okay. This is the ESC summary slide, which sort of summarizes all that I have said.